Welcome back, future RNs. Finishing up Unit 7, Suicide and Non-Suicidal Behavior. So we talked about a few new words: suicidal ideation, thinking about killing yourself; suicide, the intentional act of killing oneself; suicide attempt, carrying out an act or acts with the intent of death; and a completed side, a self-injurious act that results in death. Watched a video, epidemiology, 10th leading cause of death in the United States. That's for everyone across the board. If we were to rule out adults and just really look at pediatric patients, suicide's in the top 3. There's one completed suicide every 11 minutes in 2019, and that number is underreported and honestly probably has increased in the last 3 or 4 years. Military is always concerned about suicide rates. They are increasing, right? We hear a lot about the 22 a day campaign. However, suicide rates are increasing in adolescents, especially pediatric females, and across the board. So really, we need to be concerned about suicide with everyone. Risk factors. We always have to ask about a previous suicide attempt, because that's a huge risk factor, as well as suicide in the family. Substance use, mood disorders. Do you have access to a lethal means? Having a gun at home increases your risk. History of trauma or abuse. And what we often forget about, professionals are considered a higher risk for suicide. This includes doctors and nurses. Other risk factors: losses, right? Legal difficulties, financial, academic failures, bullying, chronic pain, and chronic physical illness, right? A person who, just found out that they have chronic stage 4 cancer, and I call it chronic, I don't know why I did, but stage 4 cancer, right, is at a higher risk than someone who found out they have a totally treatable and curable form of cancer. But also a risk we have to think about is the exposure to the suicidal behavior of others. There are such things as suicide clusters. We see those a lot in adolescence. We saw them after 13 Reasons Why came out a few years ago. Warning factors: talking or writing about death, dying, and suicide, comments about being hopeless, right? I always ask, do you think you have more reasons for living, or do you think you have more reasons for dying? Alcohol and drug use, someone who usually is very sociable is withdrawing, having mood changes. A big one is if someone expresses feeling trapped. Suicide is the ultimate flight when we think about fight or flight. They are giving up the fight and they are choosing flight. So if someone feels trapped, their only solution to getting out of it in their head may be suicide. Protective factors. I don't know what I've done to get this keep skipping so fast. Protective factors: having access to healthcare, right? Texas is last. We have so few people who have access to healthcare. I'll post the statistics one day when I think about it. Strong connections, right? Which is honestly why religion plays into it, because you have that community support with church, regardless of what your religion is. So having family, having a pet, having friends that you can turn to is one of the most important protective factors. Having contact with medical providers and being able to problem solve, right? Having resiliency. So how do we assess? Those things that we assess, risk factors, all of those, right? Previous history, family history, super important to ask. But we also look at protective factors. But we have to remember, just because I have a whole bunch of protective factors, it does not necessarily detract from the risk factors. If someone was sad or depressed and all of a sudden they're like, I feel so relieved, that's a huge red flag that we have to watch out for, because they could be happy and at peace because they finally have the energy. They made the decision to kill themselves. Social support's huge, right? How are significant others? Do they have family? Do they have someone who can turn to? If there is a history of a suicide attempt and a suicide plan, we have to assess their intent, lethality, injury, right? Do they have access? If someone says they want to shoot themselves and they do not have access to a weapon, we might be like, okay, how are you going to, do you have a plan to get a weapon? And it might be a huge process where we're like, okay, not likely to happen soon. But if we have a patient who has access to a gun and they say they're going to shoot themselves, huge red flag that we need to look at, right? What are their medical conditions? Who do we see first if we're going to prioritize these patients? What's their psychiatric diagnosis? Is it a patient who is diagnosed with stage 4 cancer who's 2 weeks post starting an SSRI with major depressive disorder, who has access to a weapon and has a plan to shoot themselves? I mean, they hit all of the red flags, right? Maybe their husband left them following the cancer diagnosis. Happens quite frequently. This is a suicide risk assessment. We looked at the CSSRS, the Columbia screening in class. That's when we see a lot used in our area in Austin. This is one from the National Institute of Mental Health. We skip that video. I'm going to skip it now. Verbal and nonverbal cues, right? I'm going to blow my brains out. Lets us know, hey, this patient's, we got to do something. If a patient says my family would be better off if I weren't around, okay, are you going to move across the country? Like, what do we do? Well, we ask, are you having any thoughts of killing yourself? Right? And nonverbal, are they meeting with lawyers to get their will in order? Are they giving away, here's my favorite sweatshirt, here's my favorite CD? And what do? We ask directly. We have said this all quarter, right? Are you having thoughts of ending your life? Are you thinking about killing yourself? Do you have a plan? To take all threats seriously, but we do have to look at the lethality. Hard methods, right? You're more likely to die quicker. If someone's going to go up to the top of a 50-story building and jump off, that's a hard method, right? If someone's going to ingest pills, right? Maybe they take 2,400 milligrams of ibuprofen. That's a soft method, right? It's not necessarily going to be a fast death. If we find them, there might be something we can do. And do they have access? If they do have access, if your patient wants to overdose on a medication and they have a 90-day supply of a tricyclic antidepressant, they have access to a more lethal means, right? And our nursing diagnosis and psych that we're always going to prioritize is risk for suicide. So what do? None of y'all knew about mental health first aid, right? We have to teach, we have to educate, we have to decrease the stigma of all healthcare providers and everyone across the board. Safety, right? Even if you're out with a friend and your friend tells you that they want to kill themselves, we're not going to let our friends go home on their own. We're going to stay with them. Same thing on patients on a unit. If we think they're at risk or they're danger, we're going to put them on a one-to-one. I handed out copies of a safety plan, right? What are your triggers? Who can you call? What are some coping strategies that you can use, right? Identify things worth living for. 988, right? That's the National Suicide Prevention number now. Shortened to a 3-digit number, right? Or even 911. Call someone, right? Most of these resources are still good. This National Suicide Prevention Lifeline, you can also now call 988. So interventions, antidepressants, right? Pharmacologically, it's going to be what is the underlying cause, right? Antidepressants for depression or anxiety, bipolar lithium, antipsychotics, right, our second gen, and anti-anxiety meds for those with anxiety problems. Levels of intervention, prevention. This is at the basis. We need to teach coping skills. We need to teach resiliency. We need to teach that mental health first aid, right? Make sure people have access to healthcare. Treatment, when you come into a facility, when you go to the ER in a time of crisis, and postvention, right? I've got this whole slide on it, often looks at the survivors. We often sometimes have to support healthcare providers because healthcare providers are exposed to suicide in their patients, right? But especially when we're talking about survivors, the family members, there's guilt, there's shame, there's abandonment. Why did they do it? We don't always have an answer. And sometimes I know, one of the big ones was Robin Williams, one of the bigger individuals who have completed suicide in America. Everyone's like, can you believe it? What happened? And we don't always know the thoughts and feelings of the individual who completed suicide. But we have to do our best to look at the thoughts and feelings of that survivor, to help them process through it, to not focus on the deceased, and to remember following the death of anyone, the hardest time is often in the future, right? That first birthday, the first anniversary, going through Christmas, all those kind of major important events where that person is no longer there are hard. We have to encourage the development of the support system in survivors and provide resources on provide information on community resources. You also have non-suicidal self-injury, and this happens for a lot of reasons, right? It can alleviate physical pain, right? If you have emotional pain, and numbness inside, if you cut yourself, feel something. It can be a way to avoid a situation, get attention, accept responsibility. For anxiety, this is not an intent to end one's life. It's a coping skill, albeit a maladaptive coping skill. Cutting, burning, scratching, scraping, right? These are deliberate acts. Shallow but painful. Non-suicidal injury happens a lot in adolescents and young adults. In times it's taught, kind of like we talked about that suicide cluster. You have a friend who's doing it, this peer sees it, they was like, hey, let me try this. We have to assess the injuries, what's triggering them, how often they're doing it, what are the wounds like. Oftentimes they keep re-injuring the same area, often infection going on, they're not being cleaned, they're re-picking at it. We have to watch our boundaries, especially if you're working medical, right? If someone comes into the ER, if someone comes into the clinic and they have short sleeves and scars on their arms, right? We shouldn't react. We need to be professional and matter of fact when dealing with it. 6-step approach, we got our nursing process, right? We have to limit set for safety, work on self-esteem, coping skills. This is a maladaptive coping skill, this non-suicidal self-injury. So what do? We teach adaptive coping skills, right? Holding ice, snapping a rubber band, those little gel pens, drawing on yourself. And we get the patients into a maintenance phase where they're doing okay. So what interventions can we do? We have to care for the injuries, first aid, bandages, clean the wounds. Maybe they need antibiotics, right? Develop a therapeutic relationship, teach adaptive coping skills. Look at what the underlying mental health disorder is, right? Is this a patient with depression? Is this a patient with borderline personality disorder, right? What's going on with the patient that we can treat? Here's some videos on suicide, self-harm. Kevin Hines, if y'all have questions, let me know. That is it for suicide and